I believe we've started recording, so I can see everyone's here for the first substantive item, so I'll start the meeting. Welcome everybody to the rather hot June edition of Health in Hackney. Can I thank everyone for joining? I do understand some people are even actually joining. I won't embarrass them from holiday, so I very much appreciate their attendance and thank them for doing so. By way of introduction, this is the start of the new municipal year, and historically what's happened is that there's had to be the election of the chair and the vice chair. There's been a constitutional amendment whereby that is deemed to have been done at full council. So I was elected chair and Councillor Patrick as vice chair. We're joined by two new members of the commission for this municipal year. Welcome to Cllr Turbet Delof, who's also our mental health champion, and she's here in the chamber with us. And also Councillor Garcia, welcome, who's joining us online. Can I also pass on my thanks to Councillor August Canley, who's left the commission after a number of years of service. Can I also welcome the new chair of the GP Confederation, Andreas Lambrianu. Welcome, Andreas, and thank you for joining us. I have had apologies for absence from Councillor Adebayo, who's at a conference, Helen Woodland, and Councillor Samatar. Just to go through the very normal pieces of housekeeping, this is obviously a hybrid meeting, people in the chamber, people online. Please keep yourselves muted unless you are speaking. If it's your item, please keep the camera on. Please don't start conversations in the chat because it's not being monitored. Please make sure you unmute when you're speaking. Members of the press may be watching. We are being live streamed. We are being recorded. Item number 4 is declarations of interest. I haven't been notified of any. Are there any declarations? No, I know Councillor Samatar normally gives a standard one, but she's not here today. So I'll then move on. Item number 5 on the agenda, just going through that briefly, is the appointments to the INEL JHOSC. So that acronym stands for the Regional Health Committee. And I understand that the councillors who Hackney can send 3 individuals to be on that. We've just finished our rotation of chairing it. The 3 individuals who we're proposing to put forward are myself, Councillor Patrick, and Cllr Turbet Delof. And can I just ask for everyone's agreement for that, please? Agreed. Thank you. And thank you to Councillor Adams for your years of service on that committee. That's appreciated. With having done those matters of housekeeping, therefore, can I then move on to the main, we've got 3 substantive items on the agenda. The first one is in terms of the Air Quality Action Plan, which officially runs from 2021 to 2025. I'm grateful we're joined by Dave Chew, who's the manager responsible, Tom Richardson, who's one of the environmental project officers at Hackney, Jane, who's our public health consultant, Dr Husbands, we all know, is our Director of Public Health, and also Sam Kirk, who's our Head of Sustainability and Environment. And also I'm grateful for Suhana Begum, who's our Senior Public Health Specialist as well. You'll all recall that we had this matter before us a year ago now, where I think we had a leading expert come to talk to us, and we asked for it to come back to get an update on the extent there have been improvements in this last year. And certainly, I think we were discussing it before, we've certainly got some questions. So we've scheduled about 45 to 50 minutes for this item. So Dave, is it over to you to start? And then maybe for sort of a 7 or so minute presentation amongst either you or your colleagues, and then we'll fire into questions. Does that sound okay?
Yes, thank you. Thank you. I'm Dave Trew, so thank you for this opportunity to come back and update. I will do the presentation sort of straight away, so I'll just need to share my screen for those.
Dave, you look a bit like you're in a panorama documentary trying to conceal your identity. Of the diet. I mean, I'm fine. I'm not sure if members whether it's affected. I mean, it doesn't really bother me, but I don't know if there's any way you could put a light on or not, or would that
yeah, just bear with me. If I open the curtains, it's just too bright with the sun.
No, fine. Then leave it. Leave it. It's only a mild thing. Leave it.
Yeah. Okay. Right. So hopefully you will be able to see my screen, and I'll start the slideshow. So just let me know if you can see the screen.
We can. Thank you.
Perfect. Okay. So as I said, my name is Dave Trew. Thank you for the introduction. I will be presenting tonight with my colleagues Tom Richardson and Suhana Begum. Tom Richardson is working in my team as an environmental projects officer, and Suhana is here from public health. And we'll sort of switch between the slides. But to start, as you said, that there was a presentation last year by Dr Mudway, and it outlined a number of studies looking at the health impacts from air pollution. I think that he focused on some studies which maybe looked at some of the health impacts which are not well known. So it was looking at the brain function, sort of the capacity of lungs. So those of you who were here last year will remember it, but just to say that that was presented, and then we followed it up looking at the air quality monitoring network, what that monitoring data that we have is showing, and then our action plan, which was approved in August 2021. So it was sort of in the early throes of it. So tonight's presentation is going to be more focused on the update since this time last year. I'm not going to recap all the health impacts which Dr Mudway went through. I will give a little bit of background about the health impacts from air pollution, and we will cover some of the emerging studies and evidence. But we'll really focus on the air quality data, what that's telling us, look at some more the outcomes as a result of changes in UK legislation, and then we'll focus on the air quality action plan and some projects and some work that is sort of starting to take place and which will be ongoing. So we'll finish with that. So as I said, I'll recap a little bit of the health impacts of air pollution, but please excuse me that this is not the presentation by Dr Mudway, which was really interesting and really informative, but this does just set out that we do focus on some of the pollutants which have been identified as having a health impact. The reason we focus on these is because based on the sources in the situation in Hackney, these are the ones which are still potentially having a health impact now. For nitrogen oxides, the pollutant which has a health impact is nitrogen dioxide. But essentially nitrogen and oxygen combine when there's combustion. So we can see from the sources here, all of these involve some form of combustion, and it's fossil fuel burning. In those conditions, nitrogen and oxygen come together, it creates nitrogen dioxide, but it's a very reactive chemical. So it will break down in the presence of sunlight, and we will see lower levels of NO2 and high levels of ozone. So this again was covered, but it's just to explain. And for those of you who who've seen the alerts from the Mayor of London, we do actually have high air pollution at the moment as a result of the buildup of ozone with the hot weather. For the nitrogen dioxide, we can see that a lot of the health impacts, as you would expect, is on the respiratory system. So with the air pollution being inhaled, it's going to impact on the eyes, nose and throat. It's going to get into the airways, into the lungs, But then obviously it will have impacts on lung health, but it will also have impacts on heart conditions. For the particulate matter, this also is related to combustion. So we see similar sources, maybe a slight variation in the apportionment. So which of those sources is has a greater impact on particulate matter 2.5. But also it's important to note that with particulate matter, because it's not a description of the composition, it's a description of size. So it can include anything. So there are natural sources such as sea salt and windblown dust. And then there's other sources such as construction, which will generate dust. And with the impacts from particulate matter, there's a lot greater range. So I think that some of that was covered by Dr. Mudway. And as I said, he looked at the impacts on brain, on cognitive behavior. So looking at its impacts in association with dementia and Alzheimer's, and also in terms of its impact on lung health. But what is really sort of focused, or has been a focus, is how it does impact range right from pregnancy right through the whole life cycle. So I'm just going to hand over to Suhana from Public Health to talk a little bit about this and some of the studies that have emerged.
Thank you very much, Dave. So you can see this image on the right here, which has been adapted from the, it's been taken from the Chief Medical Officer's annual report last year, which focused on air pollution. And you can see here that, you know, one of the reasons why air quality is so important is because it impacts the population across the lifespan. So from pregnancy right through to impacting children, adults, as well as the elderly. And there's a list of different impacts, the health impacts that it has there. So starting from pregnancy, it can, it's being linked to low birth weights. In asthma, in children, it's been linked to sort of asthma and slower development of lung function, and more sort of wheezing and coughs in children, which is some of the things that Dr. Mudway picked up on in the presentation last year from the Cllr study. And then in adults, again, it's been linked to a number of sort of long-term conditions like asthma, coronary heart disease, stroke, and lung cancer. And in the elderly, it's also been linked to sort of physical health issues like decline in lung function, as well as kind of other health issues like dementia. Next slide, please. Thank you. So just to sort of think about some of the health impacts of air pollution. So you'll see from the line graph on the top left-hand quadrant there that the blue line is the Hackney mortality that's attributable to particulate air pollution, and the black line is the England level. So you can see that Hackney sits above the England averages for a mortality that's attributable to particulate air pollution. So I think one of the main things that we wanted to get across really is that there is no safe threshold of exposure to PM 2.5. So the lower the levels, really, the better it is. And as Dave mentioned, there's a number of kind of studies that are recently coming out and kind of looking at the health impacts of air pollution on kind of development. So some of the studies we've just picked a few studies here. So the first study here is from the Cllr study. So last year, Dr. Mudway presented their study, which is called the Cllr study, which stands for Children's Health in London and Luton. So last year, I think he presented sort of some of the very early findings of his study, and some of their early findings are starting to be published now. So we've picked one of the studies there where they found that children living in London are at risk of developing lifelong conditions, including poorly developed lungs, asthma, high blood pressure, inattention, and hyperactivity and mental illness. So you can see that there's real sort of wide varying health impacts. Looking at sort of some of the other studies on adults, there's a recent study that looked at air pollution across European cities, and they found that actually if some of these cities took action to reduce their improve their air quality and reduce kind of some of these pollutants in the air, that by complying with the WHO guidelines, they could actually prevent, almost 50,000 deaths per year. And by reducing NO2, they could prevent almost 80,000 deaths per year. So there's definitely, a real case for taking action against kind of improving air quality. And I think, as Dave has already mentioned, there is now sort of more recent data that's emerging that's suggesting that being exposed to high levels of air pollution can really adversely affect cognitive function. So this kind of just gives you a real snapshot of sort of some of the health impacts, but it's very wide ranging and it's across all sections of the population.
Suhana, can I just understand? Can you just go back at one slide?
Yep.
Just to understand, so we're all with it, the graph top left of the fraction of mortality. So it's if you could just blow that up again. Can we just blow that up? Just so we're looking at that graph top left, and just to be absolutely clear what that shows us and how what the methodology is to arrive at that data set. So essentially it's showing that Hackney, being the blue line, is just shy of 10%. So if I've got it right, what that's saying is just under 10% of total mortality in the borough is attributable to particular air pollution. Is that right? Is that what that's saying?
That's correct. Yeah.
And how is that arrived at with confidence? I mean, just to be crude about it, if say in the top, how do you arrive at that figure evidentially?
So I think this is, I think this would be sort of looking at the cause of death, and I think it's quite difficult. It is difficult to tell, as you're saying, sort of with confidence, because very often, the cause of death can be linked to many, many different things. So, for example, we've said in the slide afterwards that being exposed to air pollution can actually cause lung cancer, but we know there's other, somebody might be a smoker, for example, which will also cause lung cancer. So there is different. So I think the cause of death it's when it's attributable to factors such as air pollution, but I'm not sure of the exact methodology, but I can definitely look it up and kind of get back to you if that's something that is of interest. But I'm not sure exactly how it's attributable.
Sandra, I see Sandra's hand there.
Yeah, thank you, Chair, and thanks, Suhana. It's not a very specific answer to this. It's a more general point about calculating what you call an attributable fraction. It's a very sort of standard epidemiological calculation that enables you to allocate, or assign blame, if you like, to different types of risk factors. And so that's how we can say what proportion of lung cancers are attributed to smoking, or what proportion of diabetes is attributed to obesity, etc. So it's a calculation. It's not an exact attribution, as in each person who died, who'd been exposed to air pollution, had a post-mortem examination that said that air pollution caused this particular condition in this person. So it's a population level calculation.
Thank you. I think I've got it. So in other words, you may say, for example, that X number of individuals died in Hackney because of a lung condition, and then you plug into that an algorithm which says that being the case, normally you attribute such percentage to air pollution factors. In a very crude sense, we're looking at. Yeah. Okay, that's very helpful. Thank you. Carry on, Suhana, and then I've got further questions coming from members after.
Okay, thank you. I'm just going to hand over to Tom for the next slide.
Thanks, Suhana, and good evening, councillors and chair. So I'm just going to touch briefly on the WHO guideline values, which were raised in the previous slides, and I'm also going in the following slides focus on the picture in Hackney, as well as some changes in government legislation over the last year and a half. So the World Health Organization values, these are guideline values which are based which are purely set on the health evidence, or the evidence of health impacts. In Hackney, in summer 2021, our cabinet adopted a commitment to meet the WHO guideline values, which at the time had been in place since 2005, and we committed to meet those for both nitrogen dioxide and particulate matter, so both PM10 and PM2.5. At the time, the World Health Organization guideline values for PM were lower than the UK air quality objectives, and were the same for nitrogen dioxide. However, following Hackney's adoption of that in September 2021, the WHO released an update to its global air quality guideline values, which revised those down quite substantially. And this was in light of the substantial new evidence of health effects, for example, the studies that were discussed previously. So the comparison to the original guideline values from 2005 and the revised guideline values is shown on screen. So as you can see, as I mentioned, they are revised down quite substantially. Our current position, and it's a position that is taken by other London boroughs as well as the Mayor of London, is continuing to work towards the 2005 guideline values at present. I just want to touch, however, on the interim targets, which are for countries and organisations to work towards as incremental steps towards a progressive reduction in air pollution. And these are much more focused on feasibility and practicality, with each of the interim targets associated with stepped reduction in health risk. So while our adopted values from summer 2021 are higher than the 2021 guideline values, our PM values match to the 4th interim target out of 4. And for NO2, it's the 1st interim target out of 3. So there is still some relation there. But just want so I'm now going to touch on the picture over the last year. So Hackney, as well as all other local authorities in the UK, are required to report on air quality. They report against a number of pollutants under the local air quality management framework, and we report those against the air quality objectives. Every year we're required to submit an annual status report on this. Our most recent one for the calendar year 2022 was submitted at the end of May to the GLA. So we have the results of that, but it's not yet public. Hackney has a network of monitoring stations. We have around 140 diffusion tubes, which are inexpensive non-automatic monitors to monitor nitrogen dioxide. And these allow us, a wide, expansive monitoring and an inexpensive way of monitoring nitrogen dioxide, focusing on a main pollutant from traffic over a wide area. And we're also, alongside those diffusion tubes, we have an automatic monitoring network, and that's the only way for us to monitor particulate matter, which focuses on nitrogen dioxide and PM10 and PM2.5. So the map on the top right shows where we've got a range of monitors in terms of our diffusion tubes and automatic monitors. So in 2022, despite the lifting of lockdown restrictions that we saw, which could affect our results in 2020 and 2021, we actually did see continued improvements in nitrogen dioxide concentrations. And one of the example of a trend is shown for some of our diffusion tube sites on the bottom right there. We actually saw only one site exceeding the nitrogen dioxide objective in 2022, which is a substantial improvement on previous years. In terms of PM10, which, as I mentioned, is monitored at a lower number of sites based on the fact that we use automatic monitoring, comparing that to the air quality objectives, which for PM10, for example, is 40 micrograms, we're well in compliance with that. But comparing that to Hackney's adopted WHO guideline value, we're currently at or just above that value of 20 micrograms per meters cubed. So very similar across the borough, with values between 20 and 22 micrograms per meters cubed. And for PM2.5, we're monitoring that at our Old Street monitor, which is a long-term monitor that's been in place for over 20 years. we actually did comply with our adopted guideline value. So that was 9 micrograms per meters cubed this year. And of course, in terms of the monitoring network, we are continuing to focus on monitoring where it's needed the most, where we have identified areas that are still close to or above the objectives or the values we're working towards. And that's always kept under review to make sure that we're capturing all of the air quality issues in the borough. So I'm just to finally touch on the government legislative framework and some updates in the guidance. Quite a lot's happened over the last year and a half. So we got the Environment Act in 2021, which set the government a legal requirement to set new targets for PM 2.5. The proposed target from the government was 10 micrograms per meters cubed, the same numerical concentration as we adopted in Hackney and in London, but that was to be met by 2040, so that's 10 years later than the 2030 that's adopted by Hackney and the Mayor of London. There was also a proposed population exposure reduction target of 35% by 2040, and this was compared to a 2018 baseline. When those went out for consultation, Hackney did respond to the consultation, and we did question the ambition and especially the time frame of compliance. You know, the Mayor of London and many London boroughs have set targets for 2030, and we also did highlight some issues surrounding the feasibility of the exposure reduction target, for example, whether we've got robust information on the baseline. The current network of monitoring for PM 2.5 is much smaller than PM10 and NO2, for example, and whether, for example, it would use modelling, so just seeking some clarity on that. The government did meet its own deadline to set that target, but it was adopted in November under the Environmental Targets Regulations 2022, so that's now something that's being worked towards at UK government level. And finally, and most recently, the government did publish a new air quality strategy framework for local authority delivery. So this was published at the end of April, which actually did follow a very short consultation of only about 10 days. And then it was published a couple of days afterwards. But we did, again, look at that and we did respond. There are not a great number of new powers or a large amount of new information for local authorities, but there are some welcome commitments. And we know, especially for those that remembered the presentation from last year, how it really does require UK government and even sort of international framework to deal with pollutants, especially PM 2.5. So having that is very welcome. A couple of things just to mention, we now have a civil regime for breaches of the smoke control area that Hackney is consolidating some very old legislation, which will make it much easier to enforce smoke control, the smoke control regime, which was previously a criminal regime. There is some improved public information frameworks, better communications channels such as air quality alerts and improvements to access to online data. We're also seeing indoor air quality considerations for the first time considered, which is mainly around messaging, but it's good to see that it's now being implemented across the UK. And a couple of points on PM 2.5, for example, designing out emissions in development. And in Hackney, we do have planning policies to those of that effect, and we have London plan policies to that effect, such as air quality positive. So it's very welcome that we're seeing that at a national level. So that's just a summary, and I'm going to head back to Dave now, who will give you an update on our actions from the Air Quality Action Plan. Thanks.
Thanks, Dave. Could we just wrap this up in about a few minutes? I think I've got a lot of people with questions, if that's okay.
Sure. Okay. So I was going to just cover our action plan, because I think this was like a big thing, is the update, is what have we been doing? So we know that air quality is a problem. We know we've got the data there. So just in last August, it was a year since we had the adoption, and we did some comms just saying, actually, we've done these 10 things already in the first year, one of them being the commitment to the WHO guidelines, which Tom was just outlining. Also last year, we presented some guidance from NICE and Public Health England, which has now changed its name to the UK Health Security Agency. But just quickly, these are sort of bullet point advice that came from that guidance, and I wanted to just sort of set out some of the things that we've done, which kind of shows how that guidance translates into action on the ground. So the infrastructure and support for active travel that in our recently published or recently submitted ASR, we outlined the work that we've done to support walking and cycling through improvements to our parks. So Hagston Park, Shoreditch, London Fields. We've got funding for improvements to the West Reservoir. But then other things such as just putting in drinking water fountains and having sort of cycle parking places. For the planning side of things, we developed this code of construction practice, which provides advice to developers on how to mitigate some of the impacts which inevitably occur with construction, but they can actually take steps to make sure that that's minimal. And Hackney also produced a child-friendly supplementary planning document. So this is about how child-friendly is a development, and I think that was used for the first time with the Shoreditch Park development. And then how sort of like the targeted interventions at local areas. The icon there is for school streets, but we are leading on this school streets program, and I think we've now got 49 in place. I think some are, or most of them are permanent, but some of them might be temporary. And we're also doing things kind of on a local level, such as targeting areas with engine idling signs. So I just wanted to sort of quickly say, you know, how the guidance actually translates into what we do. I'm conscious of the time. I know you've got questions, but I think probably one of the big things is about our work in terms of traffic schemes and how we have been inputting into this to analyse the impacts from the traffic schemes. So as Tom mentioned about our monitoring network, we've actually been investing in increasing our automatic monitors so we can monitor PM10 and nitrogen dioxide and provide real-time information which is available on a website, which is Air Quality England. But then we've also looked at what are the impacts with an LTN in place, and if it wasn't in place, using dispersion modelling. So these results are on our webpage, and so you can go and see the reports. And the image there on the right is just one example. It's showing where there was an improvement in air quality as a result of, in this case, it was the low emission neighbourhood at Stoke Newington, which are the green, but then we can see that the yellow and orange show where air quality is the same or higher. So what that has meant is that we can actually focus on those areas and do further studies to look at what the impacts are there and are further improvements to the transport scheme required. Another project that we've been working on is we had funding from DEFRA, so over £300,000. It involves mainly developing this web tool, which is that middle image, and it will provide advice to people, to residents, and we're developing this in conjunction with residents, so they help us to design what it is that they want. It is going to be featuring air quality data, it will have pollution alerts, but it will also give some health advice and things which can be done to help reduce their exposure. Prior to doing this, we engaged GAP and they did a survey of residents, and they will be monitoring the project throughout its 2-year delivery to see how behaviour changes. And we've also developed a short video, which is for residents, that they can then see this and they can also engage in a training programme that we're delivering. And the second session of this training programme will be on Thursday, which is Clean Air Day. So we'll be giving that. We'll also be using this video for our social media. And just back to Suhana for an update regarding the JSNA.
Thanks very much, Dave. So we've obviously talked quite a lot about the sort of health impacts of air pollution on a sort of more general level. But in terms of on a Hackney level, we do have local data that we look at. So we have published the Quality of the Local Environment JSNA. It's been published on the Hackney and City of London Health and Wellbeing's website, and the links are in the slide deck there. So this was written in 2019, and it is based on older data and evidence. And we are looking at producing a new fact sheet over the summer, which will include some updated data on some of the key indicators related to outdoor air quality. So this will help us get sort of in conjunction with sort of the data that Dave's team collect on the sort of particulate levels. This will help us understand some of the health impacts of air quality on our local residents. And then I'll just hand over to Dave to wrap up.
Thanks. Yeah, so I'm wrapping up. It is just what the next steps will be. So we will continue to deliver the Air Quality Action Plan. The annual status report has been submitted to the GLA, so they will review it, and they normally provide some comments and feedback in the August. So once that's all been done, we will publish that. The fact sheet to complement the JSNA, which Suhana was just outlining. That project, which is funded by DEFRA, we'll be launching the web tool probably at the end of August, and we'll carry on training the cohort of volunteers, but also extending that out to healthcare professionals. And we'll also be working with Regen and planning. We're looking at making sure that when a new scheme goes in place, air quality is considered, but also looking at getting some before data. So we've got the before and after for the analysis. So that's the end of the presentation, and hopefully some time for questions.
Thanks, Dave. I know I've got Cllr Adams and Cllr Binnie-Lubbock, and I think there'll be other questions as well. Can I just a couple of things just to start off? I mean, I'm struggling to understand why London, probably one of the, up there in the world as one of the largest cities, if I've got this right, no borough is adopting if this is what you're saying, is adopting the new WHO standards that have been in place now for 2 years. I was struggling to understand why we are not adopting them straight away, and why we are letting a strategy run its 4 or 5 year course before even considering doing that. I mean, it just strikes me as, but shouldn't we be adopting that from the get-go? And why are we waiting, presumably, for a strategy to run its 5 years sort of technical shelf life before adopting those targets? So I'm sort of struggling there, and sort of slightly frustrated that we're not adopting those, I suppose, is my first observation. And my second observation is, Giles, can we just bring up, if we can, the heat map for where the NO2 was worse? This was in last year's presentation. I think Giles is just going to share the screen. Just going to come up now.
See it?
Yeah, it's coming up. So this was, I think, one of the standout images for me last year when we had Dr Mudway, because essentially what we can see here is the various levels of NO2. And unsurprisingly, it focuses around where the main artillery roads are, or boundary roads are, in the borough. And that's understandable because of car use, but then married with Dr Mudway's research base about the significant health impacts of the people that may be living or going to school or regularly walking on those roads, sort of, where is the strategy specifically to deal with the mitigating measures for those really high use areas? So I appreciate a lot of the great stuff you're doing relates, a lot of it, school, street, other things, great stuff, no criticism, but it relates to the areas that are already a lot better off. Where's the 10-point plan to do what we can to put, it's not all in our control, but to put HEPA filters in schools, like Dr Mudway was suggesting, such as green barriers along those roads, to really deal with those high density areas of NO2? And shouldn't we be developing a very clear strategy to deal with that and trying to bring that down? So I suppose those are my two opening sort of remarks, and then I'll let you go, Dave, on those further questions.
Okay, yeah, thanks. So the first question then is in relation to the WHO guidelines. Just in our action plan, we did have it it predated the 2021 guidelines. So we had it as an action that we would commit to adopting the WHO guidelines. Obviously, they changed, but they are separate. So there's nothing to stop a change being made irrespective of the 5-year lifetime of the action plan. But I think it goes back to what Tom was outlining in terms of those new targets. Yes, they are health-based and they are stringent, and we should be working towards them. But even in that target, they set out interim targets because they realised that it's a staged progression in order to reach that. So I think it's you know, the WHO set out kind of a realistic step, not necessarily the timeline, but it was saying work towards this, then move to the next one, then move to the next one. So what we've adopted is the fourth stage, the fourth and final stage, prior to those final levels which are set out. So I think that what we are driving towards is that reduction. So we are effectively working towards those tighter guidelines. Does that explain kind of?
It does, but even though if you go to page 20 of the plan, that what's been presented, say, to us, I don't know what's presented to Cabinet, is top right, is there's still the data set on the hating on a sort of base analysis is okay or good, is still at the 40 level.
Yeah.
Whereas I'm not seeing to us, and I don't know whether Councillor Coburn is presented with it, but clearly even if we're working on those interim targets, where's the transparency of that data set going before politicians regularly locally so it can be measured and looked at and reevaluated? I'm just not seeing it on what we're looking at.
Yeah, I think it's a fair point, and I would say that it's been looked at, but because we have these sort of slightly different sort of parameters that we work to, so what we are required to do with our reporting, that report that I mentioned that is delivered to the GLA, we have to report against the air quality objectives which are set out in the strategy. That's our reporting requirement. We said, yes, there is that, but as you quite rightly say, we could say, you know, it's all green, all good. We know that's not the case. So we've said in Hackney, we need to go further and we need to you know, be more ambitious. So we've adopted those targets, and I think we need to, as you say, be more transparent about where we are against them. I think in terms of that adoption, I suppose this 2020-22 is the first kind of full year of data that we've had, which we're just reporting now. So I think we are going to look at more and more how we present that against the WHO objectives.
And my second point about the do we need a specific strategy with respect to the high NO2 areas?
So I think that's really what the Air Quality Action Plan is designed to achieve. So we have got a whole borough declaration. So we're saying across the borough, we are going to implement measures. But we recognise that, you know, as that image showed, I mean, one of the things just on that image which was there, that was from GLA data from 2013. In that same slide, it does actually show how the air quality has moved in 2016 and 2019. And you'll see that those colours are sort of changing to green and blue. But our Air Quality Action Plan is setting out it for the whole borough, but also recognising those hotspots and trying to focus on it. So, as you say, school streets, it might be, it's protecting children who are more vulnerable, but it might be on a more residential road rather than on those high pollution hotspots. But I think that there are things, so I know like sort of we're already part of the ULEZ, but looking at the studies coming out from that about the reduction in pollutant levels as a result of the ULEZ, that's going to impact on those main road networks. So I think it's just about wrapping it all up into a whole package of measures, which is the Air Quality Action Plan.
But what about something like the standout recommendation from Dr Mudway about what you can do would be HEPA filters in schools on those roads? Why aren't we thinking about that?
So with the the schools, but there is a green screen program, so we're looking at putting in new screens. I think there was 2 that was done last year, but it's part of an ongoing program. I think what we did look at is we have a monitor in a lot of the schools, and we also did modelling that I was mentioning. And I think what is showing is those the levels at the school are obviously, compared to the HEPA objectives, needs work. You know, we need to improve. I think that we just need to maybe prioritise that, but I think it needs to be done as a programme.
Okay, thanks, Dave. I've asked too many questions. So Councillor Adams was first, and then Councillor Binnie-Lubbock, and I see Sam Kirk coming. If I go to Councillor Adams first, then Councillor Binnie-Lubbock, and then Sam, and then Cllr Turbet Delof. So Councillor Adams.
Thank you, Chair. Thank you, Chair. On page 25, you kind of talked about development of web-based tools to reduce exposure to pollution. So that web-based, is it only for outdoor pollution or both indoors and outdoor pollution? That's my first question. And the second one is that we have all these measures in Hackney. Can you tell us if all our neighbouring boroughs are taking the same measures that we are taking in order for us to actually get the full benefit of what we are doing? Because if they are not doing what we are doing now, if they are doing less than what we are doing, I'm not sure if we are getting the full benefit. So if you can comment on that. Thank you.
Sure, thank you. So the 2 questions. The first on the web tool. So I did rush through that a little bit because of time, but it is funding that we bid for. We were successful. It's a joint project with Hackney, with Tower Hamlets, Newham, and City of London. It will be like a website which will provide advice to people, but we are looking at means by which people can access it without having to have their own laptop or smartphone. And the advice that will be given, it is going to encompass indoor air pollution. It's not something that we have a regulatory role in. I think that we need to be providing advice, particularly in relation to sort of the indoor pollutants, such as the cleaning products, some of the solvents associated with furniture, and with damp and mould. So we'll be looking to give that advice, but we certainly don't do any monitoring within people's homes. On the second question, how do we compare to other boroughs? So the action plan that we have put together, it is based on a template which the GLA produces. They've said that here's a menu that they want boroughs to adopt all of these, but you can also include specific actions which are for your borough. So we can go above and beyond, and we've got 47 measures in our air quality action plan. And obviously there are opportunities, and each borough will maybe bid for their own funding for a project. So that web tool project that I mentioned, that is something which is being done jointly with 4 boroughs. Then what we will do is we will share the lessons that we learn with other London boroughs, so that they can maybe look at doing something similar, in the same way that projects that they engage with, they will share their lessons with us. So I think the bulk of the actions will be the same, but then there will be specific projects which are related to individual boroughs.
Thank you, Dave. Councillor Binnie-Lubbock.
Thank you very much. Thanks for the really interesting presentation. It's great that Hackney's adopted these, ambitious targets and more ambitious than sort of are required. And I sort of want to echo what Councillor Hayher said around, how come we can't get to the new revised guidelines. But picking up on what officers were saying around the interim targets, I don't quite understand how these interim targets actually do align with what the WHO are asking for. Do the WHO guidelines have sort of set dates and give a guideline on how to move from what is our target to the targets that they've set? Those next stages in the interim targets. And sort of following on from Cllr Adams' question, King's College research for Camden has said that local authorities would struggle to meet these ambitious targets due to toxic air coming from outside of its control. And so I'm wondering, as part of this, as well as the activities we're actually taking, we're doing inside the borough, what are we doing in terms of lobbying to get more joined up work going and for more ambitious targets from above, as it were?
Thanks. Okay, right. So in terms of the WHO guidelines, no, and Tom, you can jump in here, but
yeah.
I have not seen any timescale that they've associated with it. I think what they've said is, you know, moving from where we were to what they're proposing, and they're purely looking at what levels impact on health. It's not looking at feasibility. And when I was certainly outlining the sources for particulates, there are natural sources. Some of the episodes that we have in London, and it's always sort of makes the news because it sounds bizarre, but it is caused by dust from the Sahara. And it's because obviously there are natural sources. So, you know, you can't deal with that. So I think it's looking at what it is that we can actually deliver. And with the WHO, as I say, they set these 4 interim targets. There's no timescales for them, but I think what they say is we've got to get there, and it's not possible to suddenly overnight get from where we were to what is proposed. So if we work towards those stages, so we're looking at, as we say, for the particulate matter, it's the 4th one and the one immediately before the one, you know, the ultimate guidelines.
I just wanted to add something that is quite pertinent from the WHO guidelines themselves on the interim targets. Obviously, the World Health Organization deals with places across the globe, you know, places in South Asia that have very, very high concentrations of PM. Their interim targets are based on stepped reductions in health impacts based on the evidence. And again, they wrap in the feasibility and the practicality of meeting those. So they are setting those interim targets for say, countries or cities that have concentrations in the hundreds, that they would first get to the first interim target, and then the second and third and fourth, and they are showing demonstrable reductions in the health effects. So that's where the interim targets comes from. And just to comment on the objectives and the EU values for when they were in force, is they're again based on feasibility and practicality as well. So the WHO are purely on the health effects, and that's why they're so low in comparison to some of these interim targets.
Thanks, Tom. And your second question was in relation to things which are outside of our control and the lobbying sort of aspect. So I think with, it kind of depends on the pollutant, but with some of the sources, particularly the nitrogen dioxide, which is a reactive gas, most of that is probably going to be generated within the borough. Not all of it, but probably a lot more so than the particulate matter, because that will disperse over a wider area. So I think in terms of that, because there is a greater dispersal of particulate matter, there does need to be more joined up work in. And I think that certainly Hackney looks to work with London councils and with other London boroughs on Pan-London projects. We've been involved in a Pan-London project tackling emissions from, it's called NRMM, non-road mobile machinery. Effectively, this is the plant that's used on construction sites, which doesn't have to meet the ULEZ for vehicles because it's being used on a construction site. And they said, no, actually, we will impose the standards on those. And Pan-London, we will go around and monitor construction sites. So that's just kind of one example of how we work with other London boroughs to deal with things which are maybe on a regional level. In what Tom was outlining, where the government is consulting on actions, so the air quality strategy, the targets for PM 2.5, we as Hackney have responded to the consultations. We said, you know, we need to be more ambitious, and I think we take account of, you know, the issue in Hackney, you know, the levels of pollution and the impacts on health. So I think that we do have lobbying role to play, and I think we are certainly trying to use that either through London councils, working with the mayor, but then making our position known to central government.
Thanks, Dave. Sam, I think I saw your hand, and then I'll bring to Cllr Turbet Delof.
Yeah, sorry, I've got the light behind me as well, so another panorama shot, so apologies for that. Dave's actually covered some of the points that I was going to raise about the 2013 data, and that we are seeing improvements in that. In terms of the Air Quality Action Plan, there is 47 actions, and it does cover quite a few different departments across the council to pull together to take action on this. And I just wanted to come back to a point you made, Chair, about the Mayor and Councillor Coban being involved. I know a lot of the areas fall within street scene, and I know that the Mayor and Councillor Coban have lots of meetings with street scene to talk about how to reduce air quality, and obviously the other associated impacts with LTNs and school streets. And we're providing that data for all of those reports and everything, so they do get sight of that. And then one of the point that I was going to make is just touching on the lobbying aspect as well. We'll respond to, like recently, and actually throughout all of the airport expansion consultations that have come out, we've responded to all of them, including the recent one. Even though the city airport expansion has been given the go-ahead, we even still responded to that, saying that although planning permission has been given, we still don't necessarily agree with what's going on. So I just wanted to update on that.
Thanks, Sam. Councillor Turbet Delof.
Thank you, Chair. Thanks very much for this very useful report. My questions are pretty brief and has been asked already. This is related to air quality, which is great, that has improved. My question, or more concern as well, is for residents who continue to, especially in our ward, continue to tell us they're very worried about boundary roads. So these monitoring stations, which I had to say, thanks Dave for sending this to me last year, but I had a surgery and I didn't get back to you. Thank you for doing that. So monitoring stations, are they placed in boundary roads, or are they sort of picking up on what traffic and pollution is happening in Hackney roads that are close perhaps to schools, where children are attending? That would be really good to know. And then the last bit is just about this air quality banding. I appreciate you said that maybe things were done a bit rushed in for this, I think, this part of the presentation, but it would be good to understand what this means, because it's brilliant that we can know where we can avoid high levels of pollution, but I'm worried about what this means for living in those areas, for those communities, businesses as well. What does this mean for businesses? That would be really good to hear. Thank you.
Dave Johnson.
Sure. Yeah. Thank you for the questions. In terms of the monitors, so there was a project and there's funding being given, and it is in relation to assessing the impacts of the impacts on air pollution as a result of the changes to road schemes through the low traffic neighbourhoods. So as part of that, we have hired 4 monitoring stations for 2 years, and they are going on the boundary roads. So I can say one is in place, Homerton Library on Homerton High Street, one on Amherst Road, one on Queensbridge Road. The 4th has literally just gone in this week. Well, the power's just gone in, so we should get data from that probably next week, and that's on Dalston Lane. So all of those should be picking up the where the impacts are going to be greatest. But the thing which I wanted to say is it's not just the monitoring. We actually did this really detailed dispersion modelling assessment, which identified receptors in the areas and looked at boundary roads and the LTNs to look at those, the difference in the impacts with it in place. So as I said, I did just go on it briefly, but the reports are on our website. And I say that there's 4 going in as a temporary thing for 2 years, but there will be 2 permanent ones that we will procure over the next 12 months, so that we will have that then for ensuring continuity of monitoring data. The second question was in relation to the web tool, and I think it's a really important point. We have been working with residents, sort of volunteers, on the information that they want to see in that web tool. And exactly what you just said is, how do you give advice to people who maybe live on roads where there is high pollution? And I think that's exactly the challenge we've got, and it's coming up with certain pieces of advice in terms of how you can ventilate your home while ensuring that the impacts from the outdoor air pollution are not brought in, but also covering the indoor air pollution that we mentioned. So it's a difficult one, but we're trying to find some simple tips, some pieces of advice that anyone can do regardless of where they live.
Thanks, Dave. But the four you mentioned, were they, because there's a reference to another four in the presentation, are they all to measure PM 2.5 or PM 10? Although they NO2 as well.
Sure. So so we have the permanent one in Old Street, which is the long-term one that measures nitrogen dioxide, PM10 and PM 2.5. We've got one other permanent one on Green Lanes, which just measures NOx. The four that we mentioned, the four in the presentation, these are hired for 2 years. They measure NO2 and PM10. The two that we will get then, which will be sort of permanent and will be in place before the four get taken out, we're looking to have PM 2.5 monitoring in at least one of those, but preferably both.
And when we're looking at that map on page 20 with all the sort of like mainly green sort of dots on, is that because there are all monitoring stations in all those locations?
Yes, but they're the diffusion tubes, so they don't provide the same level of data. So they're giving us a monthly mean, whereas with the monitoring stations, we can get, you know, 15-minute mean, hourly mean, etc.
And just, sorry, just so we know as politicians, what's the sort of cost, just so we can understand the sort of proportionality cost here, what's the sort of cost of one of these top range that give you real-time monitoring? I mean, what are we talking about?
So approximately £10,000 per monitor. So if you get a monitoring station with the 3 monitors in, you pay 30,000 for the monitors, and then probably another 8,000 for your enclosure and sort of all the bits that go with it.
Thank you. I mean, I think we're past our time, and so I'm going to have to, I mean, wrap up. I mean, just, I mean, I think what would be maybe helpful for next year if this comes back, I think we would probably want it to sort of keep a yearly check on this, would be, for example, for all those stations that might just be the tubes, as I think you call them, and the more sophisticated monitors, to actually get an understanding about what the average reading was for last year vis-a-vis this year, so we can actually see year on year change or not, and just understand it. And also then in a separate column, just understanding, you know, both internally measuring it against the old 2005 WHO guidelines, but also against the 2021. So we've got internally at least a stretch target there, even if the strategy is not updated. So like a complete data set across that portfolio, and also on that heat map that Giles showed, if that's 2013 data, what's the best we've got currently in terms of the current situation? I think the point Cllr Turbet Delof, and I think I was making there, is if you marry Dr Mudway's research about the significant health impacts, and you think if you're a child living on that road and the significant health impacts that are possibly being suffered by some of those really higher NO2 areas, I suppose the point that's driving it is, are we really doing everything we can to educate, inform and mitigate, bearing in mind what evidently seems to be quite significant health impacts for those living on or working or schooling on those roads? And do we really need to focus down on real priority or real focus on those high density areas? assuming that the 2013 map still sort of replicates is the current situation. I don't know because we haven't got the updated one in front of us. So do you think that may be something that maybe next year we could maybe have some more focus on?
Yes, I can see that Tom has got his hand up, so I think he's probably going to want to jump in and explain what we have got.
I mean, definitely something to focus on next year. But Chair, if you are interested in some of the data in our annual status report, I can follow up with you and other councillors if you so wish, with some more in depth on that.
Yes, please. I mean, yeah, it's just to really understand where we are, and I think in particular, I think the concern this committee has got is those residents living, working, schooling on those roads.
Definitely understood.
Now, Dr. Mudway's report is are we doing enough? Are we doing everything we can? If everyone really knew, if you take Dr. Mudway's example of stunted lung growth of 2 egg sizes for somebody that might be in one of those high density areas, are we fulfilling our obligation and doing everything we can to educate, inform and mitigate, I suppose? Okay, I'll leave. Yes, if you could, Tom, follow up on that, that would be great. And then with that, then I'll and thanks all. I mean, it's great work, and we're obviously sort of trying to push you to be the most striving local authority out there, and that's that. And so please take our comments in that vein. Not that we don't appreciate the great work that you're all doing. Thank you very much.
Thank you.
So with that, then I will draw that item to a close. And can we then move to item 7 on the agenda? And it's the local GP. In January, it feels longer than that to me, but perhaps not to you. So I'm grateful. In the chamber, we're joined by Dr. Kirsten Brown, who's a partner at Spring Hill and the Lawson practice, and also our local clinical lead. We're joined by Richard Bull, who is our lead commissioner for primary care. We've got Sally Bevan from Healthwatch Online. We've got Andreas Labriani, who I introduced before, who's the new chief exec from the Confed. Dr. Patel, I don't quite know, is online. Great, Dr. Patel, thank you, and Dr. Khan as well, who's also in the chamber, who is a partner at Spring Hill. Just to set the context, I think initially some of the concern was from sort of various bits of evidence that I think it was the GP patient survey, followed by possibly the information that a private practice group was setting up in the northeast of the borough as to whether there was greater access issues in that area, and that wasn't necessarily to point fingers at those practices, but more to a question of, does extra resource need to go in? Are the demographic factors in play there? And it's just really understanding what the evidence base was as to whether there was a greater access issue. I don't think there was any suggestion in terms of quality, but more just in terms of access that was being experienced by that area. In that demographic area. And so I'm grateful for the presentation. And so I don't know, Kirsten, did you want to kick off? And then I'll throw it open for questions.
Perfect. Brilliant, thanks for that. Yes, so as you said, I'm Kirsten Brown. I'm the primary care lead for City and Hackney. I am also working at Spring Hill practice, which is in the north of the borough. I'm a GP partner there. And as you said, we were here 6 months ago. I thought it would be useful just for me to summarise a little bit of what I said at that meeting for those who weren't in attendance. And then I'll bring in some of my colleagues to go into a little bit more detail regarding the points you mentioned, Chair. That's okay. I think I started the last meeting by saying that it is being a GP is I believe, still a wonderful job. I think my colleagues here will agree, and it is a real privilege to look after patients from cradle through to grave, and to develop those relationships, those working relationships with patients, and that's what make being a GP. That's what's unique about being a GP. I think we're here primarily to talk about access, but I think we mustn't forget the importance of continuity of care and patients, knowing our patients. And I think sometimes that gets overlooked, but it's so important for high quality and safe patient care, as well as good patient experience. I think it is getting incredibly difficult and increasingly difficult for practices to meet the demands on our services at the moment. And I would say, I mean, I've been a GP in Hackney for nearly 20 years now, and I think we are working harder than ever to try and meet the demands upon our services. And I think that's due to a variety of factors. There's no one thing, but it's a variety of different factors, including an aging population, increasing demands on secondary care with high waits, which we have to help patients manage in the community. There's also a push for more care to be happening in the community, close to patients. And I think that's absolutely right, but we need to make sure the funding follows the patient care. And so that as care moves from secondary care into primary care, we need to ensure that that funding follows that patient care. This is all on a backdrop of a workforce crisis in general practice in the whole of the country. We don't have enough GPs in this country, and this particularly affects inner city areas such as City and Hackney. So despite saying that, I think that we have shown in the pack that we brought in January, and also the packs that we shared with you all today, that actually City and Hackney general practice has been pretty resilient. And we can see that in terms of access and also in terms of outcomes for our patients. Just some figures from the pack today, you can see that we have more GPs in Hackney than in other areas of North East London, and also compared to other areas of London as a whole. We are offering more appointments per 1,000 patients in City and Hackney than other areas of NEL, and also we're high for London as well. And that also goes for face-to-face appointments. More than 50% of our appointments are offered on the day that the patient requests them, and more than 90% of patients are spoken to or seen within 2 weeks. So access remains good on the whole in City and Hackney, I would say. How have we done this? Well, we have done this through proper investment in primary care over the years, through the CCG and now through the place-based partnership. And this is particularly through our enhanced services, which we are supported to deliver through the GP Confederation. One of these contracts is the duty doctor contract, which means we have a consistent offer for urgent on-the-day care for all practices in City and Hackney. And this, I believe, has resulted in our low levels of 111 calls, which you can see compared to other areas of North East London. Patients in City and Hackney tend to call 111 less than other areas. And I think that's due to our access and due to the duty doctor contract. We also have high levels of recruitment to our additional roles. This is a centrally organised enhanced service through NHS England, where primary care networks can employ other roles to help provide care for our patients. And in City and Hackney, we have a very good history in the last few years of recruiting to these roles. So we have physios, pharmacists, social prescribers, mental health workers, to name just a few, in many of our GP practices through this additional role scheme and through our primary care networks. And these roles have been really, really important in helping us to provide good care to our patients. They provide increased access, but also real expertise for patient care. I think we've also, in City and Hackney, embraced new ways of working in general practice. We look at our data, we look at new ways that patients can access our services alongside traditional models, so things like online consultations. And many practices are employing new ways of providing care through clinical triage. So I'm going to stop there. There's a lot more information in the pack. I would like to hand over to Richard just to talk about some of the changes to the contract, which the GP contract, particularly around the area of access.
Thank you, Kirsten. So clearly the interest in access is not just coming from Hackney or the city, it's coming from National as well. So much so that National have produced an access recovery plan for general practices. One of the things it wants to sort is getting all practices onto a modern phone system. There's nothing more frustrating than hanging on the phone for half the morning trying to get through to your GP practice. So it's a contractual requirement that practices will move on to a modern phone system, but also there's the national funding available as well to help practices make that change. And that means that the phone systems will be able to do things that you would expect it to do in the 21st century. So your practice to call you back rather than hang on in the queue. The data that's going to come from those new modern phone systems will be helpful as well to practices in terms of planning its capacity in response to its demand. It will help, it will help understand the quantum of patients who fail to get through to their practice. So sorting out the phones is one thing. There are other solutions to phones as well, and that is accessing your general practice online, so online consultation. And Kirsten mentioned that. Clearly that's already in place, and that was a requirement during the pandemic that practices, well, it was sort of accelerated during the pandemic really, that practices opened themselves up to online consultation, and that's taking on more and more. Not necessarily all practices are embracing that fully. Some of them are relying still on a very traditional model of access. And I think where that's working, I think that's absolutely fine. But I think increasingly we're seeing that practices see the benefit of moving to more online traffic, or indeed total online traffic, by adopting a total triage model, which means every single patient enters their health problem online, and that's triaged back at the practice. If a patient can't do that themselves, then somebody in the practice team will do that on the patient's behalf. So that means everybody gets a fair crack of the access whip, because everybody's case is seen and ascertain whether they need to be seen that day, whether they need to be somebody else in the practice team, not necessarily the GP. So that could be the first contact physio, who's almost always better at physio issues than the GP, or the social prescribing link worker, or many of the other extended practice roles in the team that Kirsten mentioned. I think practices are great about identifying and working through and finding their own solutions to problems. I like to think that the government believes that, because it's incentivized practices to do that, to come together as part of their primary care networks and to look at their access data. So looking at weights on phones, looking to see, how many people are calling 111 during the day, those sorts of important metrics, and come together to produce an access improvement plan. They've been given funding upfront to do that, which is great, but then there's an additional incentive if they can demonstrate demonstrable improvements in terms of patient experience, etc., and they get some additional funding to plough back in
every PCN is being offered.
Every PCN in the country. So that's equally available to the 8 PCNs in City and Hackney And I've been meeting with the PCNs to talk about their improvement plans. And I think if you set practices a challenge, they'll set themselves a high target to achieve as well. They want to do the best. I know that they want to do the best for their patients. So I think it'd be very interesting to bring to future date the outcome of those improvement plans to this committee.
Presumably, Richard, they would need to have the telephone system in place to be able to monitoring the data. Well, I mean, depending on what telephone system they've got, because they were not going to know how many people are not getting through at 8 o'clock. Or what. So, I mean, what every practice is now being either as part of the contract or incentivized to upgrade to a new telephone system that has those monitoring capabilities.
That's right. A lot of practices have those modern phone systems already. But there are other ways of looking at patient experience. So patient surveys, asking patients is not necessarily looking at phone traffic.
Just before we go, just to understand, because I mean, have you sort of done we've got something very helpful from Health Watch that sort of I know is an interim sort of piece of work where they've sort of tried calling practices and how long they were waiting for, whether they managed to get through and didn't. And it's the first time I'd sort of seen somebody pulling that together. I don't think they would accept it's not a perfect piece of research, but it's indicative. It's an interesting snapshot. But what as part of this plan that the PCNs, you should get a comprehensive, far more thorough data sets across what every practice to then sort of fully understand all these metrics to then.
That's right. Yes, we've got data packs for all practices, and that includes patient experience data, including data that's been produced by Health Watch. And when Health Watch share with me the latest draft of what I'll be sharing that with practices and the PCNs too, to help inform their improvement plans. I think it's a really valuable piece of work.
Thank you.
What I'd like to do next, if it's okay, is introduce Dr. Taseen Khan to talk about specifically the North Borough, so Springfield Park PCN, because I know that was something that was raised at the last meeting. So Taseen, as the clinical director for the PCN, Springfield Park PCN, will talk about specific issues in that area.
Thanks, Kirsten. So, so as Kirsten mentioned, I'm a GP at Springhill Practice and Joint Clinical Director of the Primary Care Network. So very briefly, Kirsten's already mentioned the two purposes of PCNs is to have recruited additional roles that we've been very successful in so that people get the right care at the right time. So we've got 16 staff in total. But actually, we've gone over and beyond that and recruited other roles with some of the funding that has come from PCN. So we've got, for example, a PCN nurse that's shared amongst all three practices, so Stamford Hill Practice, Greenwich Road and Spring Hill, that focuses on childhood immunisation, prevention and health inequalities. And just going back to what you mentioned about the demographics, so just some headlines about the North. So Springfield Park is very different to the rest of Hackney. I'm sure everyone here knows that. We've got a significant, so up to about 40% of our population is under the age of 18. And we also have a really high proportion of pregnant women. So approximately 11% of our population comprises pregnant women. And then other sort of focuses in the PCN is trying to reduce health inequalities. So in particular, we have an issue with no uptake with childhood vaccinations. So that means we're perpetually going through vaccine preventable disease outbreaks. At the moment, we've got a whooping cough outbreak, which is getting weak. In last year, it was poliovirus found in sewage, and we can pretty much guarantee that that came from Stamford Hill. And then in summer 1819, as I'm sure you'll remember, there was a measles outbreak affecting 400 children. And the reason I'm mentioning this is because this does affect access to general practice because we are in a crisis. And actually firefighting that actually takes a lot of resource. Also, we know that young people and pregnant women consult more with their GPs because of health issues. So that also means that we need to have a proportionately higher number of GPs. And as Kirsten has mentioned, there is a workforce crisis. So we've constantly got a plan to recruit GPs, but we've diversified our team using the additional roles. Yeah, if you pop onto the next slide, please. So this is, I mean, this is worth looking at. This is a population pyramid of Springfield Park, and as you can see, so the solid bars are Springfield Park, and the dotted line is the population profile of City and Hackney. So you can see that our, I mean, I always say that our population pyramid looks like a developing country with a big bulge of young people, and then economically active people with quite relatively few older people. So it is very different to the rest. The chart on the right shows that actually for one of our practices, Greenwich Road, 50% of their population is under the age of 18. So again, a very different and a very different sort of mix of population within that. Next slide, please. There's quite a few slides here, so I'll quickly go through them. But this highlights our low vaccination uptake. So whereas the rest of City and Hackney is in the 80s, high 80s in terms of uptake, we're down at sort of 33. It's got better, so we're at about 40%, but it's nowhere near where we need to be for herd immunity to keep infections at bay, and that's demonstrated through a lot of these infectious diseases that keep cropping up. Next slide. Thanks. Yeah, just some slides about how the measles outbreak affected Stamford Hill, and also first wave. Stamford Hill had the highest infection rate in the whole world of COVID-19, and that is obviously it was concentrated in the Orthodox Jewish community because of lots of factors, including multi-generation households. And then actually the inverse care law applies here, where those people that needed the vaccination actually were less likely to take it up. So we had a lot of strategies in the north, particularly in terms of outreach, engagement with the rabbinate. We employed us to work with the community. We had pop-up vaccinations, and we tried to make vaccination as accessible as possible. Thanks. So yeah, this goes into what so as well as immunization, there's also low uptake in cancer screening and also generally preventative health, and that's because of low health literacy. Obviously, the education system is particularly different in the Orthodox Jewish community, so the access point to that community is very different, and we've tried to mitigate that, and I'll talk about how we've done that. So these are the big 3 C's around why people don't attend for prevention activities. So confidence in prevention activities, convenience and complacency, and we've tried to tackle all 3 systematically since being a PCN. So as I said, we've recruited an engagement manager who has 17 years experience in the Orthodox Jewish community and is working with organizations like Interlink. She's run 2 health checks over the past year since we've been recruited, and brings together a wide range of Orthodox Jewish organizations to try and basically get the message of vaccination, but also wider prevention activities. We also have now, so they've gone from pop-ups. We routinely have a Sunday clinic for childhood immunizations that parents can bring their child to just walk in, have community outreach clinics at the Lubavitch Centre on Thursdays where a community nurse goes and vaccinates children. As I said, we have quarterly health events, and we have regular insights and feedback via public health and other stakeholders, including the voluntary sector. And as we mentioned, the enhanced access is part of the PCN contract, and that is where, as of last October, we have to open between the hours of 8 till 8, Monday to Friday, and then nationally it was mandated that all GP surgeries have to offer services from 9 to 5 on Saturdays. But we took that fight to NHS England to say actually that wouldn't suit them, and all 3 practices were part of that, because it would be Sabbath, and actually it would increase health inequalities. So we were successful, and we're the only PCN now in the country that offers extended access on Sunday, including GP services and cervical screening, as well as childhood immunizations on Sunday. So a full range of services. This is just an outline of all our additional roles that we've recruited, including future roles such as visiting paramedic, again, to try and take pressure off GP surgeries and in dealing with the right kinds of patients and helping triage that more effectively. Thanks. I've already mentioned this, so as I said, we've got a full range of enhanced access. Excellent. Thanks. So yeah, very briefly, this was our Orthodox Jewish Engagement Day that we ran last year. So over 100 women attended. We had a fertility expert. We talked about common childhood illnesses, and all three practices were part of this and helped organise this. We also offered advice about COVID-19 infections, childhood immunisations, and from that we actually set up further events around cancer, which was attended by 150 men. So we had a separate men's and women's event. So 150 men attended the cancer event and 170 attended the women's cancer event. We had one more recently, a health and wellbeing check, which was again done in collaboration with the public health, and we had a bike doctor. We gave out information about cleaning your teeth and dental health, because that is another recognised issue in the community. So we are trying to do, and again, I keep saying PCN, but PCNs comprise the three practices. So essentially, it's the practices that are doing this by collaborating and focusing on health inequalities. And we are into other areas. So we're doing, as I said, the early cancer kind of road shows that we're going to do, face events, because we acknowledge actually the barriers that exist in Stamford Hill around not being able to do online access. We have to do face-to-face engagement events with the community, as well as another exciting plan that we've got is around setting up a children and young people's health hub together with the paediatric team and community organisations. So really excited about that, and hopefully we'll have more updates in the next 12 months about how we can actually provide more holistic, closer to patients in Stamford Hill. Thanks. And yeah, some other PCN priorities. So again, I keep talking about prevention, but it is about early detection. And the idea that, I mean, if we invest more into prevention, increase the burden on reactive healthcare, give us the headspace to actually focus on better, more tailored, specific access, and also continuity, as Kirsten mentioned. So there's a lot of change. I think we are, as a 3GP series, very agile and looking at new models of working. So yeah, just some key messages that we do have a unique profile of population, and there are specific pressures in the north that Hackney don't share. But we are having some success stories with community engagement. It will take time, as with all public health and prevention strategies, but I think we've made a good start. And again, the last point is that we can't do this alone, and it requires a multi-stakeholder approach from everyone that works in City and Hackney. Thank you.
Khan, that was fascinating. I think, I mean, in some respects, it's sort of borne out. Appreciate it is just a snapshot from Sally's bit of work that Health Watch had done, and I think one of the reasons why there was sort of concern maybe at the last meeting is that it wasn't really, it was no suggestion about quality of care, but it was more that 8 o'clock can't get through on the phone. You referenced it there about one of the priorities about the digital divide. I mean, do you think, or do you know, because of some sort of evidential data sets, that there are less people doing the online process, and you're getting more people calling up, and you just that volume you just can't deal with through no part? And then is there a question that you just, or the system needs to give you more resource for more support staff on the phones in those? I mean, is that do you feel like that is a evidential issue there, that less people are using online resource, but more people are still doing the 8 o'clock telephone call, and that you can't cope with that, and you need more resource, or to think differently on that, or in terms of the access point?
I think particularly our Orthodox Jewish community is less likely to use, for example, online links or online consultations because they don't have smartphone access. But I think as three practices, we do mitigate that by recruiting probably more receptionists, acknowledging that more people will come through on the phone. I think some of the practices also have another system called patient partner, phone up and actually not necessarily speak to someone on the phone. It's the equivalent of digital access, but you can just access it through your phone. I believe that's active in all three of the practices. So there are ways that we've tried to mitigate that. And again, you know, we now run a triage system, which allows, I think it does balance out. So those people that aren't digitally able to access appointments are still a phone. And actually what it means is by diversifying and encouraging more people that can access online, that frees up the phone lines for those people that can't. And actually, hopefully, triages in Spring Hill, we've completely changed our access system as of yesterday. And I know Stamford Hill also run a triage system. So I think that's only going to improve over the coming sort of months and years, hopefully.
Is there any way to sort of gather data? And this maybe feeds on from what Richard was talking about. You may be sort of encouraged to do it anyway, but to sort of try and gather data of those that are falling off or aren't getting through at that point, or are trying but aren't, and how do you monitor those numbers that aren't getting through on the access? Have you got a mechanism to do that? Or
so if I could take that question, certainly I mean, it will be individual for different practices, but certainly for Spring Hill practice, we do have a phone system which allows us exactly to do that. So, and we have a monitor up in our reception. So I can tell you at any moment, walk into the reception at any moment and tell you exactly how many people are on waiting to be spoken to, how long they've been waiting for, how many calls we've answered that day, how many we've missed, how many have dropped off. I can tell you that any moment. I walk into reception any moment, any day, and it's always up there so that our reception man can say, "Come on, guys, look, there's 10 people waiting on a call. Everyone answer the calls. Let's get this list down." And that really works because real-time data. You can also look back, so I can tell you, I can gather that data in a moment to tell you. And I can tell you already that we've been doing total triage the last couple of days, and already we've seen by half eight this morning, we had cleared our call. It was down to 0. Of course, the calls kept coming in, but I mean that's incredible. And by in the morning we had dealt with 160 requests for by patients. And as I said, our call, there was not a big wait on our call. So the telephone system we've had for a while. We've had it for several years, and we've looked at. We've tweaked things. So having up in reception, we've done that's quite new in this year, I would say, and that makes such a difference. So for any of us to be able to walk into reception and know exactly what's going on. The telephone triage is new. We're doing the new total triage from yesterday. That's new for us.
And Richard, do you want to come on and bring Cllr Turbet Delof?
Yes, we've also commissioned support from the GP Confederation, who have expertise in quality improvement, and they can really help practices understand their data. So interrogating their electronic systems to try and work out peaks in demand so they can flex staff accordingly. And they've had some success with that, I think, up in the northeast, but also across the whole borough.
This is really good to hear in terms of sort of like the progress that's being made in Cllr Turbet Delof.
Yes, thank you, Chair. That was really useful to hear. My question was related to that, but I had 2 questions, so I'm going to go to the second one. But this bit about maybe going to 0 calls, it would be interesting to know if they don't drop offs, perhaps, because I would imagine that some people do drop, because perhaps because I'm a counsellor, is that I get a lot of people and residents who come often and say, I cannot get an appointment, so I'll be, an immediate person to be told. So I get to hear a lot of people that don't manage to get this. The other bit that I wanted just to add as my question. So I work predominantly with migrant communities. A big issue is, of course, registration across, not just Hackney. But also the language being a massive barrier. As you were saying, you're being able to see who is, waiting, and you can kind of speed things up. That becomes an issue for people that don't speak the language, and then they get very frustrated, or they're not understood, or they might need a translator. Is there any way that perhaps some sort of form of translation or some form of booking system with a basic sort of book your appointment in a number of languages becomes available in Hackney, or digitalized as well, to support those members that don't speak the language, and then some of them are opting out from actually having access to healthcare, or not accessing routine appointments and so on. Thank you.
So I think all of the modern phone systems will be able to monitor number of patients who drop off so that should be covered. There are a number of suppliers on a government framework, so practices are being encouraged to go to those pre-assessed, pre-selected suppliers who meet all the basic competences, can do all the bells and whistles, including drop-off. In terms of access for people whose first language isn't English, asylum seekers, migrants, etc., I think contacting online, if they can do that, is a great way of accessing the practice, because I know that practices then can do the translation back and then book the interpreter when the patient comes in. That sort of online I think really is very helpful for that.
Sorry, so so people can request because I've been an interpreter for many patients in the past, and we used to work with sort of like agencies or like non-for-profits that the GP will call the non-for-profit, the non-for-profit will call us. So do patients have that access themselves so they can book that as they're making the appointment? Thank you.
So what we do, if we have many patients who speak many different languages at Spring Hill practice, it's increasingly diverse, I would say, more and more. And we've got a variety of ways we can access language support. So first of all, the probably most common is using telephone interpreting. We can do that via and call the patient back with an interpreter, so have a three-way call, or we can do it with them in the room, so we have the patient in the room and the interpreter on the call. We're lucky in Spring Hill, and it's not the same for all practices, but we have many many staff who speak different languages, which really helps. We have Polish-speaking staff, and we have Spanish, Portuguese-speaking staff. So that can be really helpful as well if the patient wishes one of our staff members to translate. And then finally, we can book a face-to-face interpreter to come in through the Homerton services if need be. So yes, we do that. I would say primarily we use Language Shop, and use the telephone interpreter would be our first port of call.
Councillor Adams.
Yes, thank you, Chair. Thank you, Dr. Brown, right?
Yeah.
Right. Yeah, last time you came here, we talked about GP access. Now we are talking about it again. And I'm kind of impressed with your description of the improvement that has happened. But from my own experience and from people that I know in my ward, I don't think that experience is shared, because I've got an email here from a resident that's actually addressed to the deputy practice manager in Lawson practice. So that, it'll be very difficult for them to access. And they actually call 111 to get them to get a phone call back, and they didn't call them back. So, so what you described is very impressive, that there's been an improvement, but I don't think that experience is across board. And I know at least about 10 people that are planning to move from Lawson practice to Shoreditch Park. So people from Shoreditch Park, they have a very good experience. That's why I'm not disputing what you just said. But Lawson practice, there's a kind of sticky, or maybe we call it sticky wicket problems that they are unable to resolve there.
So I'm also a partner at the Lawson practice. I don't do my clinical work there, but I am a partner there. So it's difficult to talk about individual cases, but I know that at Lawson practice, they have a telephone system as the one I've discussed. They also do total triage, which means they do not turn away anybody that contacts the practice. They will triage every single call that comes in. There's no call tomorrow. We don't need appointments back today. They will all be triaged to the most appropriate clinician. That might not be a GP. It may be a different clinician, or it may be other advice given. And I know that we did have some issues around patient satisfaction at Lawson, but we are seeing improvements, and we are trying to work with our patients to think about how we can improve things. So as I said, it's difficult for me to comment about certain individual cases, but I do feel that our patient satisfaction is improving at the Lawson. We don't, in our patient survey, we do very well, actually, on the whole, in terms of patient satisfaction. We look at our telephone call rates and the numbers called up in the way I've just described. And as I said, I go back to, no one is ever turned away. We take every single call or every single online thing, and that is triaged. So, you know, it's difficult for me to make further comments, but certainly that's where, you know, that's as far as I can go in talking about without talking about individual cases.
Sorry, Dr. Brown, just quickly, one more. Sorry, Dr. Brown, I'm sorry to make it personal. I'm a patient at Lawson practice. I've been there for over a year now. I find it very difficult to see a GP. I've only seen a GP once, and it was a locum GP, and I don't have a personal GP. So as a patient, I don't have patient satisfaction of seeing. You talk about doctors and patient relationship, or get to know your patient. I don't have that experience. I used to have that with Wilson surgery. My doctor seems to know me, but now nobody knows me. Wilson, that's why I live next to it.
Well, listen, of course, I'm really sorry that you've had that experience, and you don't feel like you're getting the service you want at the Lawson practice. I would encourage everyone to get involved in the practice and through things like our patient participation, because we can only work together to try and make things better. We, as all GPs, and I'm not just talking from Lawson or Spring Hill, all GPs want to provide a good service. That we don't do this job for any other reason other than wanting to care for our patients. So if services are not not reaching the level of care that you would like, then I think that we should be talking. We should be talking as patients and practices about how we can try and make things better.
I am Richard, very quickly, because I've got 3 people wanting to join. And
just to follow up on what Kirsten just said there, I would encourage you to leave feedback online. There's an online platform called Cllr Opinion to tell Lawson about the care you're receiving. And I know that the Lawson looks at each and every piece of feedback they get and do respond very fully, I would say. So I would encourage you to do that. And I think your experience sort of highlights the importance of continuity of care. It's sad, but it's great in a way that the Whiston Road partners served Hackney for so long, but they did have to retire and practice did close. And then that continuity has been lost. So I think it does underline the importance of continuity, but sadly you can't guarantee continuity forever.
Thanks, Richard. I want to move on to our final item with St. Joseph's. I've got 3 people wanting to speak. I'm going to take you together and then just for a final round of answers. So I saw Sally's hand first, then Cllr Baffour, then Dr. Pantel. So Sally?
I just wanted to say, Councillor there in the chamber, you're absolutely right. It's not across the board positive experiences, and the reason why Healthwatch wanted to take this piece of work on was because we feel like we hear from people that haven't been able to get through on the phone or have struggled to get through to the GP on the phone, because I think if you can't get through, it's huge, and you're going to be very vocal. You're going to come and tell people about it. But the reason why I shared this with you guys, even though it's quite raw data at the moment, is because actually, when we looked at it, we phoned every single practice twice in the space of a week, try and get a really fair snapshot. Over half of those calls, so we talk about 80 calls in the course of a week that we made. Over half of those calls were answered in under 3 minutes, and it averages at around 82% of calls people were getting through in 10 minutes or under. So actually, compared to what we were hearing from those anecdotal people coming back and saying this is an issue, we were kind of pleasantly surprised that people are getting through more than you would think from that feedback that you're hearing. So yeah, I just wanted to raise it that was good feedback. And the interesting thing for us, which we'll take forward with the more polished report, is the wide variety of when you do get through that recorded message you get. If you'd like, welcome to Spring Hill practice, for instance, if you'd like to speak to a receptionist, press 1. Completely different for each practice, and some messages were much clearer than others. So we're doing a bit of co-production work at the moment to try and design with some of our local residents. What does the ideal good practice message when you get through sound like? What's really clear? Because some of the messages people don't really understand. If you'd like to speak to an HCA, people don't necessarily know what that is, things like that. So we're working on that at the moment to try and get a good practice example. But yeah, I just wanted to highlight, over half the calls picked up in under 3 minutes was not what we were expecting when we picked this up, and we will repeat again in 6 months and see where we are then.
Good to get a good, because I'm just going to go the others. Councillor Baffour?
Yeah, thank you very much, Chair. I think my point goes back to what Councillor Adams and Tiboff have already said. And I'm only saying this because I live in the same community with Hoxton West and Hoxton East with Councillor Adams. And I think I've also experienced the same problem in terms of complaining about the access to GPs and the issues with the GP. Even to be specific, my wife was complaining this morning that she wants a different GP. She wants to move from Shoreditch Park. So I think the data you're providing and everything is nice and it's very holistic. But I think when it comes to our personal experience, it's also count as to how you'll be looking properly to ensure that what we are saying, what we are preaching, is against what we are receiving here. So I think you try. And also said that what Councillor Claudia said earlier, for people in terms of the language wise, the person is struggling in terms of directing them to go online. What I would suggest is there should be a hub where the GPs can plug client, customer, what's it called, patients to, so that if they tell them that they don't speak, they want this specific language, they can get someone rather than asking them, because the language is difficult for them to understand. The technology, they are not, most of them are not kind of enhanced with technology. So they need a form of assistance for them to get in. How can that be addressed? And that is the problem, that is the barrier. So I think the GPs can have to come up with something that will help them to access services in terms of their language barrier.
Thank you, Councillor Baffour. Dr Patel.
Hi, thank you. So I'm here primarily as LMC Chair, but I also work very closely with Dr Brown and Dr Khan as the co-clinical director for Springfield Park. So I just want to add a little bit about the North East first. Something to understand is the funding into Springfield Park PCN. So practices essentially have kind of 3 formulas from their raw list about how they're paid. So the very old Cahill formula, which goes into the global sum for the practices, and then more recent weighted populations and very recent adjusted population through which payments into practices and PCNs are worked out. And because of the demographic that Dr. Khan presented to you all, the northeast of Hackney suffers within that calculation compared, for example, to practices or PCNs which are weighted more towards elderly, complex health in that way. It's very difficult to compare the two, but obviously the young need lots of appointments, the parents need support, the 11% of pregnant women need ongoing support throughout their pregnancies as well. So that's a really important thing to consider within access as well in the northeast. List sizes as well in the northeast. Just looking at Stamford Hill Group Practice, which is my practice, October 2020 was 15,500 and we're over 18 now. It's about 1,000 a year off a baseline of 15,500, which I think was second largest in Hackney at that time in 2020. So recruitment's a difficult thing across Hackney. Retention is really difficult as well, with the workforce feeling as overwhelmed as they are. As one of the councillors in the room said today, only had access to a locum GP. GPs aren't committing to practices as much as they used to because of the extra work that's involved and the extra stress that's involved. It's not a sustainable job for many. So they are locuming, which affects continuity, which we all want, getting to know patients, and for residents having trust in the healthcare professionals that they're seeing. So, Chair, you mentioned at the start how perhaps you might be able to help, and I've just a couple of things I'm wondering about. Estates are a huge problem. We've been talking about it for some years now, but it's difficult to get any action. And I just wonder whether a discussion within this forum, obviously not today, but if we could take something forward, perhaps where we work together on estates and a plan going forwards, and something perhaps around public health, how we can work in a more integrated way with public health, particularly if we look at access at the northeast, the growing population, the very specific needs within that population that Dr. Khan illustrated very well. I wonder if we need to just think through how we can work differently together. Conversations have started around working together with the paediatricians at Homerton Hospital. Very local, very new discussion, but thinking maybe with public health around resources, health promotion, information, these types of things. And it's really, really important to celebrate that we have Duty Doctor in City in Hackney. It's an absolutely fantastic service. When my wife was pregnant and she needed a GP, not A&E, we couldn't access a GP in Waltham Forest. That wouldn't happen in any of our 39 practices in Hackney. So that's, I mean, that's excellent. I'll leave it there in interest of time.
You're muted.
Thanks, Sandra. Yes, thank you, Dr. Patel. And certainly estates is something I think we can certainly pick up on. I've got Cllr Patrick. I'm going to ask as brief as possible because we are significantly at time. And then I'm going to quickly go back to Kirsten and then wrap this up.
Thanks. Just go back, briefly go back to the telephone surgery. I just wondered, perhaps, I don't think it's to Richard, what's going to happen about the great disparities in the telephone answering time? I mean, you've got practices who don't seem to answer at all, where people have waited for half an hour and still haven't got through, and then practices that answer within a minute or a couple of minutes, which is great. You've got my own practice, which is the Lee surgery, which people waited 27 minutes in the morning, but got through in a minute in the afternoon. So I don't know what's happening there. Perhaps it's just somebody was off sick or something, I don't know. But did you say, sorry, I find it difficult to hear in this chamber, that there was, I don't know, somebody who knows whether there's a monitor of all the people that put the phone down before they get through. And also going back to retention of GPs, and I remember when you came Spring Hill came last time, you told us about how you'd advertised so many times and you couldn't get another doctor. And I don't know if you've got one because your things seem to have improved dramatically and you seem to be doing some really good work. But we keep hearing nationally about how doctors are leaving the health service, how GPs are leaving the health service, you know, poor pay, poor long working hours. We know lots of GPs now work part-time because of the stress. And I just wondered perhaps how the council, I don't know if the council can do anything in partnership with the health service, the local GPs to improve recruitment and retention. I don't know if there's anything we can do, but and if so, what are the GP Federation doing and the local health service doing to try and recruit GPs and also nurses? And I know practice nurses is a particular specialism, and not every nurse wants to do that. And you know, some people want to work in the hospital, I suppose, like some doctors, you know. But is there something more we can do to access or grow practice nurses and let people know what a good career move it is and what support there can be for working in, because I know there's across health there's a move from GPs where services can be provided from nurses, and from nurses to healthcare assistants and GP social prescribers and all sorts of people these days. And I just wondered how we can recruit enough people to provide the people of Hackney with adequate healthcare.
Thanks, Sharon. Kirsten or Richard, over to you, sir.
Hello, Sharon. Just on the phones. So those new phone systems will be able to record people who drop off. So that can already happen now for those people who've got the phone systems, and it will happen when they switch over. I'll be looking at the report when it's properly issued. I've only seen a draft so far, it's just in draft format, and I will be sharing that with the practices. And there will be other information as well to compare that to or triangulate with. So, for example, there'll be the results from the latest GP patient survey published probably next month, which historically has shown that satisfaction with getting through on the phone is comparatively high in City and Hackney. Always interesting when you do a snapshot, for example, you know, what health watch had just done there, calling in the morning and calling in the afternoon. And you can sometimes get a very different response, can't you? We've seen that in the draft report. So also very much look forward to Health Watch doing that follow-up report, but definitely sharing it with practices and PCNs and using that to feed into the access improvement plans that they're working on.
Thank you. And Kirsten, just on Councillor Baffour's point, also on Councillor Turbet Delof's point, is there more that can be done on the language barrier point? There are other ways,
Is there more that I think they can? I mean, I think the language barrier is a huge issue. It's a huge. I mean, it's you know, it is hard for to provide to try and provide the same quality because it, you know, it does take, the translation does take time, and I think it's something that we'll work really hard towards. I think that we do recognise in City and Hackney, we try to, through our CCE contract, we try and increase some of the funding for practices so that they can access those services. So I think it's something that we do and we will continue to do. I'm not sure if there's more that.
Final word.
Yeah, so for a long time we've been investing more in general practice in City and Hackney compared to any other part of London I know, to reflect the atypicality of our population, i.e. the percentage of patients whose first language isn't English, and the amount of extra time it then takes to consult with those patients. So we give practices additional funding for that. We take the issue of access for people who don't speak English very seriously. We incentivise practices very recently to do their own self-assessment on how they provide care to patients whose first language isn't English, and we're getting those results in, and we're going to be looking at those at our next primary care board to see what improvements we can make.
Thank you. Councillor Bill wanted to come in. I said, Councillor, if we put it through email to Richard and Kirsten, because I just think if I wasn't so over time, I would take you back again, but because we are, we'll put it through email. Thank you very much. Thank you so much, everybody. It's fascinating to hear, both in terms of specifics and very helpful for us of the northeast of the borough, but also about the work that continues to be done in terms of access. I think for my 10, 11 years on this committee, that's the most sort of in-depth level of work that's been done on that 8 o'clock call access issue that has always been an issue, and I think really gets people, because as Sally was saying, most people are getting through, but for those that don't, it just leaves such a sense of disenfranchisement from the system that's what people. So that is, you know, we never really hear issues or complaints about quality. It's all, you know, it's just that. It's that for those that are on the wrong side of the digital divide, it is the access issues. The more we can do to crack that, I think that would be wonderful. And it may be, as Richard says, when we've got further work being done with the PCNs, it may be we can come back at a future point when there's greater data sets available. Thank you very much. So I'm going to draw that to a close. Moving on now to our last item, St Joseph's Hospice Quality Accounts. Jane, we're joined by Jane, who's the Director of Clinical Service and the Joint CEO. Jane, I'm very sorry that we've overrun. I'm normally fairly punctual, but so apologies to you. But over to you to give an introduction to your report.
Thank you. So I'm assuming that you've all read the report and won't insult you by reading it. I think the one thing to say is that as a non-statutory, we're not a NHS trust, so technically we can set off without providing a quality account, but we see it's a really good part of our clinical governance and welcome the opportunity to bring it to you and answer your questions, so thank you for the time. I just want to highlight our ambitions for the next year. The whole point about a quality account is we do a bit about, as well as the data about our incidents and governance issues, we do a bit of setting some objectives for the year. So our objectives for the year is mainly based around access, I suppose, and accessibility. So that starts off with our Easy Reach project. We know that people with learning disabilities are incredibly disadvantaged when it comes to accessing palliative and end-of-life care. And we know that to find any easy read materials that don't talk just about cancer is almost impossible. So we've decided rather ambitiously to embark in writing our own easy read leaflets. We have engaged a group of experts by experience who said, that's lovely, but half of us can't read anyway. What are you going to do about it? So our easy read leaflets will eventually become easy read videos. And we may be seeking some grant funding from anybody who wishes to give us some to help with that, because it's certainly with our budget, but we feel it's really important, and hopefully it will be a template for other hospices. That also includes our signage, because again, they didn't like it very much, and they had a very fair point. The other thing we're very keen to do, and we always have been at St Joseph's, we are very proud of the fact that our cancer and non-cancer statistics are almost equal, and we're one of the few hospices who achieve that. Generally, most hospices would be about 80% cancer patients. In London, maybe 70%, but we're close to 50-50, which we're very proud of. But we want to really increase what we do downstream. It's about health promotion. We do believe that palliative care can do health promotion too, and rehabilitative palliative care. So we're going to embark on a project around breathlessness, because it's a symptom that a lot of patients face irrespective of condition, and looking at a breathlessness toolkit, because we know that breathlessness tends to lead to a 111 call. So hopefully supporting people to maintain their breathlessness, taking pressure off system. We hope to finally get the ward refurbished. We had it all planned before COVID hit us, and then it didn't happen. So wish us luck. And then finally, as an organisation with an NHS contract, we have to do something called PSERF, which is a new way of doing strategic serious incidents, but it involves a whole action plan, and will mean a change for us, which I'm very excited about. And we've got some of our user group who have agreed, who've always been involved in our incident reporting, but have agreed to become part of the clinical governance committee. So that's quite a step forward. The rest of the report really, I'd rather answer questions on, but I would like to highlight that we benchmark against with Hospice UK. So that's against all hospices in the country. We're counted as a large hospice, and we benchmark against them. And in all measures, which is our falls, medication incidents, and pressure ulcers, we benchmark below the average and consistently do. And we work hard to do that. We're very proud of that. And I think I'll open up for questions because I'm aware of the time.
Thank you. And we're very lucky to have you in Borough. We're aware of the great work you do, and we thank you for it. I'm just interested to understand a little bit more about how you then achieve that parity between cancer and other illnesses, and why you use the expression "we're proud of that." So, perhaps my ignorance here, but I mean, why? How do you achieve that, and why is that a sign that you're doing well, as it were? Just to explain my ignorance. And the other question was, I noted in the report about the excellent work you're doing in terms of supporting people with benefits. I think in terms of the over £600,000. Obviously, I don't know whether you know, but obviously the council has got its own money hub that's working in a similar area, and I'm just wondering about the sort of the crossover and interwork that you're doing in relation to that.
Absolutely. So your first question about the non-cancer cancer. So last year it was 51% cancer diagnosis and 49% non-cancer. And I think what we know is that people with long-term conditions, or they will now be rebranded under the new government strategy as major conditions, but we'll ignore that, have more symptoms than the average cancer patient. So if you have heart failure or a respiratory condition, you are more likely to have more fatigue, more breathlessness, more depression, and poor quality of life than the average cancer patient. So your outcomes are worse, and your outcomes are worse for longer. And your disease trajectory also is very rocky. Most people nowadays with cancer, with modern cancer treatments, do really quite well and then sadly decline rather quickly, and I'm sure you can all think of that. If I have a respiratory condition or a lung condition or a heart condition, long-term heart condition, I'm more likely to have a very rocky journey. So I'll be quite well, and then I'll be in hospital, and then I won't come out quite so well, and I'll go in hospital again and won't come out quite so well, and it'll all be very bumpy. So we know that actually these people have huge unmet palliative care needs, and we strongly believe as a hospice in a local area with a very mixed population who have, if I'm honest, poor health outcomes generally because of inequity, etc., that we do need to meet their needs. Otherwise, we're really a bit pointless. So that's why it's important and why I'm proud of it. And then we do know about the Benefits Hub, and we link people in.
Questions, Cllr Adams and Cllr Patrick. Cllr Adams first.
Thank you for the report. Yeah, my question is just about the quality monitoring visits.
Yep.
You said you haven't had it, had a visit for a while now.
That's correct.
So when are you looking forward to have one?
Well, we don't know when.
And sorry, before you answer that one, second one quickly. The second one is about the special review investigation. You're not taking part in that one as well. So why are you not taking part in that one?
What investigation?
It's a special review investigation or investigation to CQC.
Oh yeah, I'll explain both.
Thank you.
Both are related. CQC are very out of date and coming to visit us, and there's nothing I can do about that. I would quite like them to come. They were going to come just before COVID came, and then they suspended face-to-face visits. We've been doing our direct monitoring visits, monitoring calls, and they have updated our portal, updated our information on their website. They are due to come any minute, literally any minute, but what minute they come is up to us. We had a date, and then sadly the inspector got ill, so we wait. We haven't had any quality monitoring visits, and that's really been about COVID. We deal with people, our inpatient unit, up until recently, up until really sort of maybe April, deal with people who would have been in the old-fashioned, extremely vulnerable and shielding group. And quite rightly, people would not be wandering around doing quality monitoring visits that way. So up until April, we've not really had people in. And the people who would do the quality monitoring visit right now would be our colleagues from the CCG or ICB now, and there's a bit of reorganisation going on. So we're expecting that at probably about the same time as CQC. Hopefully they won't both come in the same week. But we're welcome. And if anybody would like to come for a look around the hospice and if the council would like to do one, please do. We're very open.
Take you up on that.
That's absolutely lovely. We'd like that.
Thank you, Chair. I welcome the work you say you are doing, on people with learning disabilities, but my question is about dementia.
Mm-hmm.
You say that you're trying to improve the physical environment. And I just wondered, are you getting more people coming into the hospital, supporting people with dementia now? Because I'm not sure everyone really realises that dementia actually kills people in the end. And I just wonder what you're doing to support people with dementia who are at the end of their life, and whether you think you're going to have more people with dementia approaching with dementia and having to support them, and how you're changing your services to do that, because obviously people with dementia have different needs and different capabilities of understanding to what, say, somebody who's dying but has all their mental faculty, so to speak.
Yeah. So already we are doing quite a lot of work, particularly in the community, for people who are living with dementia. We have a project called Namaste, alongside our community specialist nurses who also see people with dementia, because actually, if possible, if people can stay in their own environment, and that's not always possible, of course it's not, then it is better for the individual, because if you're already confused and got cognitive impairment, being moved, if you don't need to be, is not good for you and can create more confusion and distress. Our Namaste service are trained volunteers and staff who go into somebody's home and they use all 5 senses to connect with the patient. There's quite a lot of research that doing Namaste care reduces things like distress, anxiety, and reluctance to have care. And we certainly know that some of the people who we are seeing and doing Namaste therapy with are often quite, when we go and start the visit, are often quite non-verbal, quite shut down, and by the end of the visit, maybe interacting and actually speaking. So we do that. We also do admit people with dementia into our wards, and we have protocols for if we need to observe somebody to keep them safe. The ward environment's as dementia friendly as any ward environment can be, and we build that into our built environment.
Turbet Delof?
Yes, thank you, Chair. I wonder if you could tell us a little bit about this Freddie Award that I think you're hoping to hopefully achieve, and how I guess my main concern is who is organizing that, how will that be achieved, and who will be managing that, because it's a consultation as well with patients in it. Thank you.
Absolutely. So Freddie is comes from the, I can never remember, it's the Institute of Diversity or something of diversity. Hopefully I might have put it in my report, and if not, I will email you the correct title.
Fairness, respect, equality, diversity, inclusion, and engagement.
Yes, thank you.
Freddie.
And it's accreditation. Freddie is about diversity for the workforce rather than our population. Our population are incredibly diverse. We want to be as diverse as possible workforce, and that's not as easy as it sounds, because for a lot of people from our communities, certainly nursing is not a profession that they encourage their children to do. So while I would like to have a lot more nurses from our Bangladeshi population, or maybe some of our other community populations, being a nurse is not something they encourage their daughters to do. So we struggle with that. The other thing that's really important for us for our workforce is to be welcoming, because our belief really is if we treat each other well at work, and we make sure that we are very accepting, you can bring your whole self to work, whatever that might be, then we're going to greet our patients that way, and that's why we're going for Freddie. So it's assessed by the Institute of Diversity, as I say, and we're working towards it. We just had an update actually, and we've got an action plan, and our assessor is very pleased with our progress so far. So hopefully we should get it sometime towards the end of the year.
Thank you, Jane. I mean, yeah, to your offer, I mean, it may be, I was just thinking that it may be something we could invite out to all our councillor colleagues, and not just the health committee, but you know, to organise a visit at some point that's convenient, convenient to you. Because I mean, you're a much appreciated, valuable institution in the borough, and we've got a fairly new crop of councillors in the last year, and so it's good to showcase your work. And we're very proud of you, and congratulations on all the metrics that you went through before about how you're above national average. So thank you very much.
Thank you.
And thanks for the work that you do, and for your staff as well. And with that, I'll draw that item to a close as well. Members, minutes from the last meeting, can we agree, please? And lastly, work programme suggestions for the year to JARS, please, by the 22nd of June to incorporate into the future work programme. And with that, I'll bring the meeting to a close. Thank you, everybody.
Thank you. Bye-bye.